Hey guys, welcome. We're just chatting with the owners, pain specialists of the Afiya Pain Clinic. So we've got Akil and Jam. You know, these, in my mind, are two of the best in this area. And I've got a lot of surgical patients that are, some of which benefit, some don't. We've been talking a lot about these types of interventions, and they're not for everyone, right? So I want to just talk to you guys because you guys know the literature better than anyone else. Who is this for? Who is it not for? Like, you know, so we start off maybe with just, you know, the patient with the disc herniation and some of these other patients. Like, who is it? Who's getting better here?
Typically, you're right. The sooner the better. It's not for everyone, but typically we always want to try to see patients earlier on when they feel symptoms, and we have a better chance of getting to the root cause. When we have one specific disc herniation in the acute to subacute phase, then we can actually think about treating that. When there's multiple levels of a different pinched nerve, then it becomes really challenging when we have to try to target that one nerve, but there's lots of nerves being affected.
And so let me just clarify, are you talking about patients with sharp shooting sciatica-like symptoms, like what we call radiculopathy, or are you talking about as well patients with claudication or spinal stenosis central symptoms where both the legs are aching and cramping?
Yeah, so those are the ones that are more challenging. When there's both legs involved, multiple nerves are being claudicated, then it becomes technically difficult for us to target so many nerves.
Right.
If it's a clear-cut, one simple disc herniation that's just touching one nerve, then that improves our outcome.
Okay. And so what are we looking at? Like, give me some hard numbers to rest on. So if you're talking about something that would be successful, let's ignore the central canal stenosis patients for now. Let's talk about the sharp shooting sciatica, acute disc. What are some numbers we could rest our hat on in terms of short, medium, long-term outcomes? Like, what percentage of people would you say are getting better from that? Would you say 30%, 50%? Like, what percentage of the patients are getting reasonable relief?
It's hard because pain medicine is multimodal.
Yeah,
right? So
okay.
This intervention is going to help. Hopefully, I never promise that's going to be a cure, but it's going to be a performance enhancement. It's going to get you up and moving and give you some pain relief so that you can start thinking about all the other rehabilitation processes.
And that's what we practice here, right? So just as Dr. Siva said, you know, we do a single injection and let's hit the L5 nerve root. If in the acute phase, we know that we actually have better outcomes because the more chronic something gets, the harder it is to treat. So we can apply that to everywhere, whether it's neck pain, back pain, knee pain. The more chronic something happens, and so the definition of chronic pain is pain greater than 3 months, right? By our society definitions. You know, we want to prevent it going from that acute on chronic. So when we see them more acute, we get them moving. The real evidence in the literature that has the most overwhelming evidence is when we combine all the multimodal things that we offer, and we try to do this in the community to the best of our ability. So that's optimizing their mental health, right? Getting them moving, encouraging them, teaching them how to pace themselves, right? So what does pacing mean? Pacing means, well, you know, we don't expect you to walk 10 kilometers today. We want you to start with small baby steps and then set yourself goals, right? And so all our interventionally trained, fellowship trained physicians, we teach that to our patients. You know, we instill confidence in them so that they can set realistic goals and not be upset or with themselves if they can't meet that goal that day, right? So every day is a new day. Like, it's like a Nintendo game. You hit the reset button. Tomorrow's different than it was today, right?
You mentioned something that's interesting to me. You said 3 months. So, like, speaking from the surgical literature, so like, we would say generally you recommend waiting 6 weeks, and then, you know, maybe you should offer a surgery for an acute disc, for example. And in my experience, I'd say the majority of, we say 80% of people will resolve without surgery, but the majority of those are between 3 and 6 months. So, like, should I be pulling the trigger and offering these surgeries and having these serious discussions yet? Or is it still worth, if someone hasn't had these options, to do that? I would think it's still worth to do it because I've seen these results.
So you know, just as you mentioned in the literature, so, you know, we look at, like, acute radiculopathies and we say, like, you know, 50% will resolve, like, you know, and we have that, another 25%, another 25%. That's, like, kind of the triphasic phase of how a disc heals, right? And so I think in the acute phase, I think interventional options are the best because you're actually, you know, even it's not a large surgery like your big scolies, which mean you've done together. It's still surgery, right? There's fibrosis, there's making a cut, right? There's a longer rehabilitation. The patients walk out of here. We've got a little bit of corticosteroid that can help the nerve heal, right? We can start them on multimodal medication. We can encourage them to do the rehab. And then, you know, most of my patients, especially young patients who have, you know, who are motivated, I see most of them resolve. some of them don't resolve, and then I send them to you for a surgical opinion, right? And I think that's like a really, really good trajectory for the patient. It's also a good trajectory for our healthcare system, right? Because it takes less resources from the system. You could be doing this on someone who actually needs the surgery, right? So
let me ask you one more question. So I have a lot of patients, they're elderly, they've got multiple medical problems. They're not interested in big surgeries, but like they have multiple levels of compression. So I don't think I deal with it well because the risk is so high. And then interventional doesn't deal with it great because, you know, it's hard to hit every nerve. But what are the options for these people? Because I don't want to just jump straight into these high-risk options. So what are we doing?
It's multidisciplinary, multimodal analgesia. Of course, I would still sometimes consider intervention to these patients just a part of comfort care, right? So if we can get them comfortable and give them an extra 3 months of pain relief from an injection, it's pretty minimally invasive, but within that 3 months, they're really focusing on the right physio, the rehabilitation, the back brace, the ergonomic changes. So again, if we can provide that comfort to these patients, then I still think they might be a candidate. I can't promise that it's going to take away all the pain, but as long as it gets some pain relief, it might be worth the try.
And motion is motion, right? So if we can have our 80-year-old live, you know, they're in their twilight years, they just want to move. So, you know, realistic expectations. We're not going to take your pain 100% away, right? But if we can reduce it by 40, 50%, that has a massive magnitude effect on their quality of life.
I think the expectations are critical too. Like if you're coming in here for an injection and you're expecting everything, the numbness to go away, you're expecting the pins and needles to go away, like you're not going to be happy, right? Our target for surgery, for interventions, for whatever, it's all pain based. And so, you know, I think that's the best way to get a bad outcome is to expect something that you can't possibly get from that treatment, right? Like that's not reasonable. So guys, I really appreciate quick chats. I think this is helpful for the patients. They don't know what they're supposed to be doing. Some people get better, some people don't. Where should we be putting them and stuff? I think it's helpful. I think it's great. Thank you so much for the chat.